I would like to talk about paraspinal muscle morphologic changes in patients with lumbar spinal stenosis. Paraspinal muscle, especially multifidus atrophy, is believed to play a crucial role in low back pain. Therefore, paraspinal muscle is focused on attention on exercise therapy in patients with lumbar spine disorders. The causes of multifidus muscle changes in low back pain are proposed neural mechanisms, diffuse muscle unloading mechanisms such as physical inactivity, and inflammatory mechanisms that be affected by increased expression of pro-inflammatory cytokines in multifidus after intervertebral disc injury. Lumbar spinal stenosis has been reported to affect paraspinal muscle morphologic changes such as atrophy, fat infiltration, and multifidus asymmetry in both sides. However, objective physical assessment and degenerative spine conditions are rarely assessed. The purpose of this study was to clarify factors associated with paraspinal muscle morphology, including objective physical and detailed degenerative spine assessment in patients with lumbar spinal stenosis. 70 patients presenting with symptoms of neurogenic claudication caused by lumbar spinal stenosis, which was confirmed by MRI, were included in this cross-sectional study. Paraspinal muscle were manually measured using ImageJ software on MRI. Total cross-sectional areas and functional cross-sectional areas in multifidus and erector spinae at mid-disc levels from L12 to L5S were measured using ImageJ software. Fatty infiltration was assessed as FCSA-CSA. Degenerative spine conditions, including spinal stenosis, disc degeneration, and endplate abnormalities, were assessed on MRI. Physical activity measured as daily steps and maximum walking distance without rest were used for objective assessment. Severity of lumbar spinal stenosis symptoms and pain were assessed through questionnaires. Results: to clarify the influence of lumbar spinal stenosis on paraspinal muscle morphology, symptomatic and asymptomatic size of paraspinal muscles were compared. As shown in Table 1, significant difference was observed in erector spinae muscle size at one level below from stenotic level. However, there was no significant differences in multifidus morphology. Next, the associations between paraspinal muscle and other factors, including spinal degenerative conditions, were analyzed using correlational and multivariate regression analysis. As shown in Table 2, disc degeneration, disc height loss, and endplate abnormalities, such as endplate defects and modic changes, were significantly correlated with multifidus muscle size and fat infiltration. Claudication distance was also correlated with multifidus fat infiltration. Spinal stenosis was correlated with erector spinae muscle size, but not multifidus muscle morphology. In the stepwise linear regression analysis, severe claudication and endplate abnormalities were negatively associated with multifidus muscle size or fat infiltration, and spinal stenosis was negatively associated with erector spinae muscle size at one level below from symptomatic level on symptomatic side. When it was analyzed throughout L12 to L5S at symptomatic side, disc degeneration and endplate defects were negatively associated with multifidus and erector spinae muscle size or fat infiltration. In conclusion, paraspinal muscle morphologic changes due to lumbar spinal stenosis were observed only in erector spinae. Disc degeneration and endplate abnormalities, but not the spinal stenosis, strongly associated with the paraspinal muscle morphology. Therefore, inflammatory, not neural mechanisms, might play an important role in paraspinal muscle changes in patients with lumbar spinal stenosis. Future studies should focus on whether lumbar muscle exercise can prevent or improve muscle morphologic changes in patients with lumbar spinal stenosis. Thank you for your attention.